Welcome back to the Deep Dive. Our mission here, as always, is to take some really dense, critical source material. In this case, Chapter 16 of Baily and Love's 20th edition, Global Health and Surgery, and really break it down.
Right.
We want to transform it into critical insights, mental anchors, and just ready-to-use knowledge for you, the learner. Think of this as your shortcut to being well-informed, designed to make your revision both thorough and hopefully memorable.
Yeah, and we're not just reading the textbook at you. This isn't a recitation, it's an interpretation.
Exactly.
We're your guides. We're pointing out the foundational concepts, the key statistics that policymakers and, leading surgeons really consider essential.
So the goal is that when you do go back and read the full chapter, these anchors we've set up will just help everything click into place.
That's the idea.
Okay, let's unpack this. This is an enormous topic. We're diving into a chapter that argues for surgery not just as a clinical practice, but as this crucial pillar of public health.
And economic development, which is key.
Right. So before we get into the stats, what are the primary themes, the learning objectives that are going to structure this deep dive?
I think the chapter really challenges the traditional surgical mindset. It demands a pretty fundamental shift in perspective.
Okay.
So the core themes are, first, we have to define what global surgery actually means. We have to move past some old stereotypes.
Right.
Then we need to establish the cost-effectiveness of surgery, which is huge because for decades, people were skeptical. After that, we have to grasp the devastating link between a lack of surgical access and, the impoverishment of millions.
And
finally, we have to analyze the practical stuff, the delivery platforms, the metrics, the workforce strategies needed to actually fix this global crisis by 2030.
Okay, so the very first step in tackling this chapter is it's just getting the words right. We need some foundational definitions. What is global health? And then how does global surgery fit into that?
Right. So global health is the big picture, the macro concept. It's concerned with the health of populations in a global context.
So that's infectious disease, nutrition, environmental factors.
Exactly. The really broad view of population well-being.
Okay.
Global surgery is where that meets clinical practice. It's surgery understood through the lens of public health. It recognizes that in individual patients' needs, what a surgeon deals with every single day, are completely linked to the population-level needs and what infrastructure is available.
So, if I'm a surgeon and I'm focused on the one appendectomy happening right now on my table, that's the micro-focus.
Yes.
Global surgery steps back and asks, hang on, can the 200,000 people in this whole district even get an appendectomy when they need one?
And what are the system failures that are stopping them? Yes, that's it, precisely.
Okay.
And this leads us to, I think, a really crucial mental anchor from the source material. It helps distinguish between the roles surgeons play.
And what's that?
We call it the retailer versus the wholesaler.
I love this metaphor. It's perfect for revision.
Yeah.
So in business terms, the surgeon in the operating theater is the retailer. Their focus is the immediate transaction.
Yeah.
The success, the safety, the outcome for that one patient.
Correct. But the global surgeon, they have to be the wholesaler.
Right.
The wholesaler's job is to meet the surgical needs of the entire population they serve. Their concern is the total burden of disease, all the trauma, the obstructed labor, the neglected cancers.
For the entire community.
For the community as a whole, yeah. They have to organize the supply chain, the training, the infrastructure to meet that huge collective demand.
And here's where it gets really interesting, because the chapter is clear that the label global surgeon it's often misunderstood.
It is.
It's not about what specialty you're in. It's about your context and your mission.
That's the essential insight. They're specialized not in a procedure, but in meeting community surgical needs based on the local burden of disease.
So that means the term applies to any surgeon, right?
Yeah.
General, obstetric, orthopedic.
Any surgeon working in a non-tertiary hospital performing life-saving essential surgeries that are driven by what the community actually needs.
So if you were the one person providing fracture care and C-sections for a population of 500,000,
you are, by definition, the surgical wholesaler for that community. It doesn't matter where you trained, you're filling that role.
this means we have to immediately talk about what we're calling the parachute problem.
Yes.
Because the public image of a global surgeon is often, a subspecialist from a high-income country flying into a lower-income country for a week or two.
And the chapter is quite critical of that model.
Why?
Because that model, it's often well-intentioned, but it is fundamentally insufficient. The source is clear. Those surgeons can only mitigate a microscopic fraction of the vast system-level need.
They're a temporary fix.
A high-cost, high-profile temporary fix.
And worse, sometimes these missions can actually undermine the local systems, can't they?
They absolutely can. They might draw scarce local resources away from the permanent hospital or create a perception of dependency.
Or they bring equipment that nobody can fix once they leave.
Exactly. So global surgery fundamentally is about sustainability and equity. It's about improving health systems that are led and staffed by local surgeons in those communities.
The goal is to support the local champion, the sustainable wholesaler.
Not to rely on temporary relief from outside.
So the ultimate aim is to fix the structural failures, the hole in the bucket, so the local team can do their job every single day.
If that distinction isn't clear, we should probably pause here for a second. Let's make this actionable for you, the learner.
Okay, check-in question.
Check-in question. Imagine you're a Ministry of Health administrator in a region with a huge surgical burden and one single permanent surgeon. You get a one-time grant of $100,000. Does a surgical wholesaler prioritize funding a 2-week visiting team from overseas, or investing in reliable oxygen, good sterilization equipment, and peer support for your one local surgeon?
The answer has to be the system,
It has to be.
the sustainable infrastructure. Because if that local surgeon leaves from burnout or lack of resources, the whole population loses access. That's the reality of the wholesaler's job.
So now that we've established the who and the how, we have to get to the why now. Why did this movement gain so much momentum?
And it comes down to two big things, right? A shift in disease patterns and some really compelling economic evidence.
Exactly. The epidemiological transition is the scientific basis. For decades, global health was all about communicable diseases, HIV, malaria, TB.
The big three.
The big three. But the source material shows that while those are, stabilizing in some places, a massive 1/3 of the total disease burden worldwide is now surgical.
1/3. That's huge.
And that third is mostly injury trauma from road traffic accidents and late-stage cancers. These are chronic, debilitating conditions that need immediate intervention.
So this change really forced health planners to reassess everything. Historically, surgery was seen as a luxury.
Too expensive, too complex, too specialized for poor settings.
What was the turning point that broke that bias?
The game changer was the World Health Organization declaration in 2015. Following the evidence from the Lancet Commission, all the world's health ministers formally declared that surgical and anesthesia care are essential parts of public health.
And the realization was revolutionary.
It was. The idea that early surgery doesn't just save lives, but it's a potent economic stimulus. It actually boosts national productivity and growth.
So the argument shifted from just humanitarian aid to hard-nosed economics.
Exactly. And economists, like surgeons, they need data.
So how did they provide the financial data to convince the skeptics?
The Disease Control Priorities Group, they identified key high-impact procedures. And the core insight was quantifying the cost of inaction.
What does that mean?
It means looking at what happens when you don't invest in timely care for common treatable things like a hernia or a simple fracture or obstructed labor.
You get high death rates.
You get high death rates and astronomical lifetime economic costs to the individual, the family, and the whole national economy.
Let's focus on that lifetime cost. If a young mother needs a C-section and dies because she can't get one.
You've lost not only a life, but you've lost decades of her productivity, her contribution to the family, to the economy.
Or a farmer with a simple open fracture that gets infected leads to an amputation.
That person is now removed from the workforce, potentially for life. They become a net consumer of healthcare. The delayed fix, the complicated septic late-stage intervention, it always costs more.
Okay, so let's talk about the anchor comparison that really got the attention of funders. How cost-effective is surgery compared to the public health gold standards?
The data is. It's pretty surprising. Surgery for specific conditions like cataracts or hydrocephalus or cleft lip repair, it's been shown to be comparable in cost effectiveness to the BCG vaccine.
Wow, that's a huge claim. The BCG vaccine is seen as one of the best buys in medical history.
It is. And to put surgery on that same level, it just completely redefines its policy role.
And the source says some procedures are even more cost-effective.
Much more, in some cases, than other crucial measures like long-term antiretroviral therapy for HIV. And this is all measured through a metric called dailies averted.
Okay, let's break that down. What's a daily?
A daily is a disability-adjusted life year. It represents 1 year of healthy life lost, either to premature death or to disability.
So public health planners calculate the cost to avert one of those lost years.
Exactly. When you do a cataract surgery, you might restore sight to someone with 20 productive years ahead of them. You've averted 20 dailies. The cost of that one surgery spread over all those years of healthy life you've restored is incredibly low.
So it's not just about preventing death, it's about preventing disability. This proves surgery is an investment that pays huge returns.
And that cost effectiveness gets even better when you think about the delivery platform.
The wholesaler approach again.
Right. The cost effectiveness is magnified when you deliver surgeries as a group of interventions within an established platform, like a district hospital.
Why does grouping them lower the cost?
Because you're leveraging fixed costs. You've already paid for the sterilizer, the anesthetist's salary, the lights. Adding a hernia repair to a system that's already doing C-sections doesn't require a massive new investment.
You're optimizing the system.
The system is optimized, and the cost per daily averted drops even further.
So the ultimate takeaway here is that surgery needs to be completely reframed.
It's not a luxury.
It's a foundational, cost-effective economic investment. Investing today prevents catastrophic costs tomorrow.
So if the economics are so clear, the scale of the failure is, well, it's just staggering. This section of the chapter has the most sobering number of all.
It's the central, shocking crisis. 5 billion out of 7 billion people on Earth lack access to timely, safe, and affordable surgical care.
It's almost unbelievable, 2/3 of the world living without this fundamental necessity.
And the urgency is just immense.
And while the crisis is obviously most acute in lower-income countries, the source reminds us that there are huge barriers for disadvantaged populations even within high-income countries.
It's an equity problem everywhere.
It's an equity problem. To measure this failure, we need a precise definition of access. And the chapter provides this brilliant framework, another vital mental anchor called the 4 lenses of access.
Right. And it's a probability model. Access only happens if all 4 things succeed.
Exactly. P access is the joint probability of timeliness, T, capacity C, safety S, and affordability A. If any one of those fails,
The whole thing collapses. You have no access.
let's break those down. Timeliness is about getting care when you need it, which is mostly about geography.
Okay.
Capacity is the stuff, the hospital, the staff, the supplies. Safety is the quality check. Are you following basic standards?
And affordability is the economic safety net. Can the patient actually get the care without going broke?
Right. Let's start with timeliness, which brings us to the issue of geographical access and a really crucial time benchmark.
The 2-hour rule.
The 2-hour rule. Geographical access means being able to reach a surgical facility within 2 hours.
And why 2 hours?
Because that's often the maximum time you have to control major hemorrhage and trauma or childbirth before things become irreversible.
And the failure rate is just profound.
9 out of 10 people in low and middle income countries are outside that 2-hour window.
And this explains why patients arrive so late. They show up with these huge, neglected cancers, or infected fractures, or perforated bowels.
Exactly. The delay makes the eventual surgery more complex, more costly, and with a worse outcome. It reinforces the whole cost-effectiveness argument again.
So let's quantify the human need. How many more procedures are we talking about here?
The world needs 143 million more surgical operations annually just to prevent death and disability. That's the unmet essential need.
What? 143 million, and when you contrast that with where surgery is happening now.
It's shocking. Of the 313 million procedures done worldwide, only a tiny 6% happen in the poorest countries.
Even though those countries have over 1/3 of the world's population.
Right. The hotspots of unmet need are concentrated in sub-Saharan Africa and South Asia. These are places where mothers and babies die for the lack of a basic C-section.
So the global community has set a target for this. What's the goal for operative volume by 2030?
The goal is an optimum volume of 5,000 surgical procedures per 100,000 population globally.
And the contrast between that goal and reality is just stark.
You have a country like Ethiopia performing maybe 150 operations per 100,000, and then Hungary performing over 23,000. The gap is terrifying.
But the chapter introduces a really interesting nuance here, the plateau effect.
Yes, this is crucial for efficient spending. While having low volumes below 5,000 correlates directly with high death rates, Doing significantly more than 5,000 procedures doesn't seem to bring commensurate health benefits for the whole population.
Wait, so are we saying a country like Hungary is doing unnecessary surgery?
Not necessarily unnecessary for the individual, but the marginal benefit to the population's health plateaus. Once you hit 5,000, you've probably covered all the essential life-saving, disability-preventing needs.
Anything beyond that is more specialized, lower volume, or discretionary stuff that doesn't really shift the big population health stats.
Right. It sets a benchmark for efficiency. 5,000 per 100,000 is the public health sweet spot. Below that, lives are being lost unnecessarily. Above that, the return on investment diminishes.
Let's apply these four lenses to a scenario, just to make sure it's clear for you, the learner.
Okay, a case study application. A young, healthy patient in rural Asia has a bad scooter accident, gets a complex open tibia fracture. He's 3.5 hours from the nearest hospital. When he gets there, the generator is broken, so the sterilization equipment doesn't work. And he needs to pay $200 in cash, which he doesn't have. Where did the failure start, and what's the final nail in the coffin?
Okay, so the failure started immediately with timeliness geographical access. 3.5 hours is way outside the 2-hour window.
That complicates things clinically right away.
Then you have a safety failure. Non-functional sterilizers mean any surgery is dangerous. And the final critical failure is affordability.
He can't pay. The hospital might have the capacity, the surgeon is there, but because T, S, and A have all failed, the whole thing collapses, access denied.
It shows why you have to strengthen every part of the system at once.
So this crisis is, at its heart, a workforce crisis. If you want to do 5,000 procedures, you need people to do them.
And the foundation of that workforce is the surgeon, anesthetist, and obstetrician, the SAO, at the district hospital level.
They are the absolute front line. But there's a tragic shortage. Many low-income countries have fewer than 5 SAOs per 100,000 people.
And the chapter shows that as that number goes up, key health indicators, like maternal mortality, get dramatically better.
They do. And just like with the volume of procedures, there's a plateau effect for people, too. The benefits really take off until you get to 20 SAOs per 100,000 population.
So that's the second major 2030 goal.
It is, but achieving it is a monumental task. It means training an astronomical 1.27 million providers globally over the next decade.
You can't just copy old training models to do that.
No way. And when you have this massive workforce deficit meeting a huge burden of disease, you have to innovate, which leads directly to the task-shifting strategy.
Right, delegating tasks to less specialized workers.
It's about delegating appropriate surgical or anesthesia tasks to non-physician health workers. This isn't about compromising safety, it's about maximizing safe access right now.
So, for example, a specially trained nurse or medical graduate could provide essential anesthesia.
Yes, because that's often the biggest bottleneck. Or in the very poorest settings, you might have appropriately trained clinical officers performing basic essential surgeries. They are the surgical lifeline in remote areas.
Which brings up a big ethical dilemma, doesn't it?
Yeah.
You're balancing immediate access for the population against the gold standard of specialist care.
You are. But the evidence suggests that for these essential procedures, regulated task shifting provides much, much better outcomes than no care at all.
And all of this is undermined by the fundamental problem of the brain drain paradox.
It's a huge issue. You have this global maldistribution. High-income countries with low birth rates have a surplus of pediatric surgeons.
Clinical redundancy.
Meanwhile, in a high-burden country, one single surgeon might be responsible for millions of people. It leads to isolation and devastating burnout.
And that burnout drives migration.
The stats are damning. 12% of SAOs practicing in high-income countries graduated from low- and middle-income countries. And 2/3 of those migrating surgeons came from the very countries that need them most.
So HICs are basically extracting the most needed people from the most vulnerable systems.
Yes. So the problem isn't just a lack of training, it's a lack of retention.
You can't just throw money at training programs if everyone you train leaves.
Exactly. The solution has to be about creating a sustainable, supportive ecosystem where these champions choose to stay.
So what are the policy levers? How do you mitigate brain drain?
The strategies are systemic. You need to give them academic recognition, global surgery units in local universities, creating a career path.
Combat the isolation.
Combat the isolation with robust remote support, grand rounds, EICU consults, so they don't feel like they're on their own.
And their soft support, too.
Absolutely. Supportive supervision, recognition, collegiality. These things are just as important as the technology.
And we have to remember the ecosystem is bigger than just the SAO.
Oh, it's huge. You need physicians, nurses, health managers, biomedical engineers, lab techs, blood bank techs. It's a massive coordinated effort.
And at the community level.
Community health workers are paramount in these settings. They're the ones who reduce the delays, who build trust, who get people to the hospital in the first place.
And we can't forget the private sector.
No, they're a huge part of the manpower in many countries. If they're properly regulated and incentivized, they can really help achieve the 2030 goals. Okay, so we've talked about the workforce. Now we have to talk about the final barrier, the cost.
We've already established that delayed surgery is expensive for a nation. But for an individual, even timely surgery can be, well, devastating.
This is where we see the poverty trap. The source defines catastrophic expenditure as spending more than 40% of your annual household income on healthcare.
40%, just for one event.
The scale of the risk is terrifying. Nearly half the world, 44% of the population, is at risk of that financial catastrophe from a single major surgery.
One car accident, one emergency C-section, and your family is ruined.
And it's not just a risk, it's happening. 33 million people every year are pushed into poverty because they have to pay out of pocket for surgery. That's a population larger than Australia.
Every single year.
And this catastrophe is felt most acutely with time-critical surgery, like peritonitis. The family has to sell their land, their livestock, pull their kids out of school.
Plunging them into intergenerational poverty just to save one life.
And the chapter really challenges the surgical profession here. That retailer model, the focus on just the clinical problem.
It means surgeons were sometimes less engaged with the economic realities their patients were facing.
The consequence is that the poorest people, the ones who can't pay up front, they often just never make it to the operating theater, or they arrive way too late.
And this creates a wealth disparity in who gets care. The source says it's commonly only the upper wealth quintiles who can get safe, timely, affordable surgery.
So access becomes a privilege of wealth, not a right based on need.
The out-of-pocket expenses for just injury care in some countries are more than the entire national health budget.
It's a massive, uncontrolled transfer of wealth from individual households straight into poverty.
So the realization here completely flips the narrative.
It has to. The focus shifts. Surgery isn't a costly clinical problem. It's a necessary social and economic tool to prevent poverty.
It's an essential public good.
So to manage all this, you need the right metrics. You need to monitor progress. And that means surgeons have to think beyond the individual patient. They have to adopt population-level metrics.
Right. Surgeons are used to clinical metrics like infection rates in their hospital. Global surgery needs broader data, like household surveys on injury prevalence or cancer screening rates.
We need macro indicators like maternal mortality and C-section rates for the whole country.
And the key metric for measuring success is delays averted.
Maximizing the healthy life years restored per dollar spent. It's the evidence that proves why surgery must be a priority.
And the ultimate quantification of the burden is so powerful. 1/3 of all global deaths are from conditions that need surgery.
That's more than HIV, malaria, and TB combined.
Which makes the historical neglect of surgery just indefensible.
It is. So, to track progress, the chapter highlights 5 core indicators.
First, preparedness, access. What proportion of the population is within 2 hours of a facility? And preparedness, workforce, the density of SAOs, hitting that target of 20.
Then you measure surgical service delivery. First, volume. Are you hitting 5,000 procedures per 100,000? And second, critically, safety. What's the death rate for surgical patients?
You need that quality control.
You do. And finally, the equity metric, affordability. Are people being protected from catastrophic costs? Because if you're hitting your volume targets but bankrupting your population, the system is still failing.
And these metrics inform how you structure the delivery of care.
The WHO lists 44 essential surgeries, and critically, 29 of them can be done at a good district hospital. That allows for a decentralized model.
And to gauge if a hospital is functional, we use the bellwether procedures as a proxy.
Yes. Cesarean sections, laparotomies, and treatment of open fractures.
Why those 3?
Because if a hospital can do those 3 safely, it means they have safe anesthesia, blood products, sterilization, imaging. It means the foundational system is working.
And in places with extreme shortages, you have to triage differently, not by specialty, but by urgency.
It's simple. Must do procedures that can't wait 24 hours. Should do that can't wait a week. And can do that can wait longer. It focuses limited resources on saving the most lives.
So finally, we have to talk about the complex role of high-income countries in all this.
Right. There are positive roles. academic partnerships, good research, some planned mission surgeries that transfer skills.
Operation Smile, for example, has really helped standardize safety protocols.
But the critiques of the parachute problem are real. You have to be careful not to draw resources away from local care or donate equipment that can't be maintained, these white elephants.
The path forward has to be about genuine partnership and mutual learning.
Absolutely. And the source highlights what HICs can learn from excellence in lower income settings.
The Ayurveda Institute in India.
A prime example, they revolutionized high-volume, affordable cataract surgery. They proved that safety and quality depend on a reliable, standardized system, not on the most expensive equipment.
So if the surgical wholesaler is the champion, what does their future look like?
The future global surgeon has to move beyond the operating theater. They have to partner with public health experts, set up hub-and-spoke models for rural outreach,
They become advocates?
passionate advocates for policy change. They have to push for affordable, equitable care for the 5 billion people who lack it. It's pairing technical skill with social justice. Hashtag tag outro. So we've covered the economics, the epidemiology, the workforce arguments. Let's finish by revisiting the 5 core high-impact messages from the Lancet Commission that really define this whole movement.
Okay, the big 5. First, the scale. 5 billion people lack access to safe surgery. Second, the deficit. 143 million more procedures are needed every year. Third, the consequence. 33 million people are impoverished by surgical costs annually. And fourth, the solution. Investing in surgery is affordable, cost-effective, and promotes economic growth.
And the final, undeniable conclusion, surgery is an indivisible, indispensable part of healthcare. It's not optional. It has to be an integral, funded part of any national health system.
And the greatest challenge, as we've discussed, isn't the technical skill. We know how to do a C-section.
It's the political will. It's the financial architecture needed to overcome the barriers and reverse the brain drain.
The pursuit of that 2030 goal, 20 SAOs per 100,000.
It requires training all those providers, but more importantly, it means creating a supportive, resilient healthcare environment where our local champions are recognized, supported, and want to stay. That's the real global surgery challenge.
We really encourage you, the learner, to use this deep dive as your framework, your ready reckoner. And now, go dive into the full text of Baily and Love, Chapter 16, armed with these anchors and connections.
You're equipped now to really synthesize the detail.
Until next time, keep learning.
And keep advocating for equitable care.
We'll see you on the next deep dive.